of frequent and protracted sexual intercourse. Hello? Undescended testes.
Yes, we can hear you. Sit, Doc.
Can you hear me? Hello? Hello?
Yes, we can hear you. Loud and clear. We can hear you.
Undescended testes is one of the commonest causes of infertility because of the temperature difference. You need a temperature of 32, 34 degrees for normal spermatogenesis to occur. We talked about chromosomal disorders. We're not going to go into details. You can have a low sperm count, abnormal sperms. You know, the sperm has a head, a body, and a tail. You can have some without head, some without body, some without tail. And then you can have a blockage of the duct, the sperm duct, and the epididymis, and then the varicoceles I've talked about. And basically what we do for infertility, if you have varicocele, then we ligate the varicocele, and then the temperature difference is removed, and you have a temperature of 32, 34 degrees, and you start having improvement in terms of function. The other ones that we can do surgically is to bring down an undescended testes, and also could do testicular biopsy to see what is happening in the testis. And if the duct is blocked, then we are also able to improve that surgically. Other diseases are benign prostatic enlargement, prostatic cancer, and prostatitis. So benign prostatic enlargement, this is if you are blessed with age and you're male and you have not been castrated, then what happens is we get enlargement of the prostate, and this is a factor of hormonal influence to the prostate. It's a factor of vascular endothelial growth factor and other factors that cause enlargement of the prostate. Now we are told that diet would influence that. Diet rich in animal proteins would then encourage prostate enlargement. Diet that is rich in things like pumpkins and pumpkin seeds, on the other hand, this started enlargement of the prostate, and can you hear me? Hello?
Yes, we lost you for a second, but now we can hear you.
Okay, yeah. Okay, so so enlargement of the prostate, when that happens, I think the urethra is squeezed by the prostate because the prostate is not able to enlarge outwardly. It enlarges inwardly and into the bladder, and that makes the urethra become long and thin, and this will affect the flow of urine. The bladder has to push against resistance, and therefore you get some symptoms which are a poor urine stream. You hesitate a bit, what is called hesitancy when you want to pass urine. You feel like you've not emptied completely because the bladder muscle gets tired, like any muscle, and puts the weight down, and that weight is actually volume in the bladder. Sometimes you feel like you want to rush to the toilet, and sometimes you cannot actually hold the urine. And then you wake up many times at night. We must qualify that in terms of frequency of urination and waking up many times at night, what we call nocturia. We know that diseases like diabetes can cause that. And the medication, some of the medications we use for treatment of heart failure or high blood pressure can also cause that. The medication is called diuretics. And therefore, perhaps you move on. And therefore, therefore, when you have this enlargement of the prostate, when you get all these symptoms, what do? We normally would subject you to medical physical examination. We do a digital rectal examination. That means you use a gloved finger to examine the prostate through the anal opening. And we also would do an ultrasound to see the size of the prostate and to see how much urine you are leaving in the bladder. The prostate is not the problem. What causes problem is the amount of urine left in the bladder, because that, when it is more than 30% consistently, sometimes it starts affecting the kidneys. And so we worry more about the kidneys. And sometimes if this is not attended to, we end up with retention and we need for catheterization. We also do the blood test for what is called prostate-specific antigen, which is a signal on whether there is anything happening in the prostate, be it infection, be it enlargement or cancer. The PSA level tends to rise, and more significantly when there is cancer. The treatment for benign prostate enlargement is basically medical. 65% of patients will do well without surgery. So the Massachusetts male aging study done sometimes about 20, 30 years ago showed that about 65% of males will not require surgery for prostate. In the past, when we were training most of the patients, once you had an enlarged prostate, you had to undergo surgery. But these days, only about 35% will undergo surgery because we have medications that work, medicines that relax the prostate, what we call the alpha blockers. Examples of that is the medication like tamsulosin and Zatro or alfuzosin. They do work very well. We also have a group of medication that shrink the prostate, what we call the 5-alpha reductase inhibitors, like example is finasteride or dutasteride. All these are available in our market. We have also now, currently, we are using some of the medicines that were used in the past for erection, the PDE5 inhibitors in low dose to also assist in terms of passage of urine. When the medications fail, then we resort to surgery, and the surgery that is a gold standard is what is called a TURP, where you insert an instrument into the urethra. Show me the diagram. You insert an instrument into the urethra and work on the prostate. The prostate is the organ where that tube from the penis passes through, and above it is the bladder, and you cut the prostate from inside, cut the obstructing bit, and suck out the cheeks and stop the bleeding. And then patients are able to pass urine within 2 days after the operation, and the admission is a maximum of about two nights. The admission is a maximum of 2 nights, and the recovery is quite rapid. Other things that can be used is laser, and you can also use water jet. You can use heat to treat the prostate, and all these are available. You can use a pin, or you can use even prostatic artery embolization, but those are experimental. So we thank you, and so that's okay. Then we also have to get follow-up. Once we do the resection of the tissue, we check that whether there is any prostate cancer or not. And so that's just a summary of who gets benign prostate enlargement. Is not found under 30. It rises with age, 50% at 60 years and 90% at 85, and gets about 1 in 6 men in a lifetime. Move on. Yeah. So we go to prostate cancer. It's a common cancer. It's the second leading cause of death, but indeed the commonest cancer amongst men, but second leading cause of death amongst men. Therefore, it means it's not very aggressive. Yeah, there are other cancers that are more aggressive, and the peak age is about 70 years. What we see in the studies we've done and the patients we see here, we are getting at a lower peak age of about 62 there. And prostate cancer kills about 13 men worldwide every minute and affects all social classes. It's more aggressive in the blacks, and the kind of prostate cancer we see here is quite aggressive. In fact, there's a lot of interest from in the international arena about the genetics of prostate cancer in blacks. It's the cause we don't know, but it's associated with a high content of animal fat. Basically, red meat, the one that is well done. There is also genetics, a lot of it. I now see patients who I treated their dads for prostate cancer coming for checkup, and indeed we end up catching the prostate cancer very early. It's commoner in blacks and more aggressive in blacks. What we have seen also, there is some geographic correlation where you find that the people in Asia and Asia, when they have a lower incidence of prostate cancer, and when you see when they migrate to the US, you find that their incidence of prostate cancer after second generation is almost the same as that of the Americans. And that means there could be some geographic correlation to this. It's not increased by sexual intercourse. It's not increased by lack of it or too much of it or partners. So we continue. Sorry, I'm getting some interruptions here and there. Okay, that we had talked about. Go to the next. Let's just show in a urine stream. Number one is one of one adult young male. Number two is maybe in the 40s. Number three in the 50s. And then you start getting obstruction from the prostate. Next slide, please. So this is a specimen of a patient. We did radical prostatectomy for prostate cancer. And what you see on the side looking like chicken wing is a seminal vesicle. The center faucets is showing the vast difference. That's the spermatic duct. And the yellow bit below is a catheter in the urethra. And the shiny bit at the center on the right side of the picture is where the cancer was. So when we get early prostate cancer, we are able to treat using surgery, where we do radical prostatectomy. So you remove all that and then attach the urethra to the bladder, and hopefully have a patient who is continent and a patient who has normal sexual function or normal erection, for that matter, because once you get the vast difference, and they will not be able to ejaculate. We do this locally. It can be done open or robotic. Other causes of it are sorry, I'm just changing to a laptop. Yeah, thank you. Other causes of other causes. Sorry. So once you do the surgery, you end up with a patient who is cancer-free, and you end up with a patient who may. Can you hear me? Hello?
Yes,
Can
we
you
can.
hear me?
Yes, we can, but
You
you are
can
having
mute?
two voices.
Yeah. Okay.
Maybe you mute one
Yep.
gadget.
Okay. Can you hear me now?
Loud and clear.
Okay, good. I could start my video. I can't start the video because the host has can still use this. So that's it. So other ways of treating prostate cancer is, especially the early type, is radiotherapy. And this one, you give external beam radiotherapy, what means that you have radiation into the prostate through the pelvis, and then you're able to kill the cancer cells. This has to be combined with the hormonal therapy, going back to the axis that we had, the pituitary gonadal axis. So you have to work on the pituitary to sort of cheat it so that it stops ordering the production of testosterone. And we call that androgen deprivation therapy. And it works. And we normally would get good results with both surgery and radiation. So for early prostate cancer, we have a choice. You can use surgery, you can use radiation. Other forms of radiation are where you can put beads into the prostate, radioactive beads, what is called brachytherapy. And we also have finer ones, which is called stereotactic radiotherapy, or the cyberknife, which are all available locally. You don't have to travel out. That's early prostate cancer. Sometimes after radical prostatectomy, you may have failure. The PSA level may not come down, because that's what we use to monitor. It may not come down, and if it doesn't come down, if it is more than 0.2, the normal being 0 to 4, if you've not had surgery. But when you've had surgery, if it is more than 0.2 nanograms per ml, then we say you have biochemical failure, and we perhaps sometimes would need to do additional treatment, be it radiotherapy or hormonal therapy. For late prostate cancer, this is one that is stage 3, 4. Stage 3, you can still have a window to give radiotherapy, a window for surgery, but you'll end up combining both surgery and radiotherapy. But stage 4, because the disease has moved beyond the prostate, you may not be able to help the patient with surgery. You may not be able to help the patient with radiotherapy. And so therefore, the radiotherapy you do is palliative. The surgery you do is also palliative. You do the TURP when they are not able to pass urine. And we use hormonal therapy in this case. And since the disease has spread to the bones, they get also bone pains. And so we use some agents to reduce the bone pains. Usually the life expectancy is short when you have late prostate cancer. We also grade them into grade 1, grade 2, grade group 1, grade group 2, grade group 3, grade group 4, grade group 5. Depending on the severity, grade group 1 being one that is low grade and good prognosis and favorable, is low risk. And then group 5 is high risk and high grade, and of course a poor prognosis. Let's move on. There is also chemotherapy in terms of prostate cancer, but this comes quite late. The main treatment is hormonal therapy. Let's talk about male sexual dysfunction or sexual dysfunction. I just want to summarize that in terms of males, the sexual dysfunction for a male to get an erection is very easy. It's just like that switch on the left. And for the female, there are a variety of switches and many things that are involved. Thank God that is not our topic for today. So we concentrate with the simple one, the male sexual dysfunction. And next slide. And we say one has erectile dysfunction when he has, a male has consistent or recurrent inability to attain or maintain penile erection sufficient for sexual performance, and sufficient for penetration. And this has to happen for about 3 months continuously for one to be labeled as having erectile dysfunction. In the past, the term impotence was used, but this was changed because impotence means you can't do anything else, not just even erection, is everything. So that was changed. And it does happen. And we have this gentleman called Leonardo da Vinci who observed that the penis does not obey its master, who tries to erect it at will. Instead, the penis erects freely when its master is asleep, and therefore the penis may be said to have its own mind by any stretch of imagination. These were just people who are interested in sexual function, and they also noted that if you are riding the horses too much, there are people who are getting more erectile dysfunction. We see that now. People are riding boda, we see them with more erectile dysfunction, but we shall also talk about the causes as we move on. That picture just shows that the penile neuroanatomy, and shows that the penis, for a penis to erect, you have to involve the brain, the brainstem, and the hypothalamus, and the spinal cord, because the brain is stimulated by visual or smell, and you get aroused through the spinal cord, through what we call the parasympathetic center around the pelvis, and then you get a few chemical changes that happen, allowing the blood vessels to the penis to expand and blood to flow into what is called the corpora cavernosum, and then it is locked in, and that's when you get an erection, and after function, the reverse will happen. Maybe the next slide would interest you. Next slide. This is just a slide that was viewed to us in 2003 in International Sex and Impotence Research conference in Marrakesh, Morocco. And at that time, they predicted that there will be an increase in erectile dysfunction. But more important is the increase in Africa, from which increases about threefolds to about 30.8 million people in Africa would have erectile dysfunction. And you can see that the increase in Africa is much more than other continents, and basically because of change in lifestyle, taking the Western diet, not being too active physically, and then you end up with erectile dysfunction. Also a factor of people living a little bit longer. And we are seeing this to be true now. We are seeing a lot of erectile dysfunction. The causes of erectile dysfunction then would be, next slide, would be either psychological, which is 50%, and normally you see this in younger men, 30, 40 and below. They have psychological issues that make them not get an erection, but the main thing is that they're able to get a morning erection when they are asleep, but during function, they're not able to get an erection. Age is a factor, of course. It declines with age, and there are many things that come with age: the prostate, the vascular diseases, weight issues, high cholesterol, diabetes, hypertension, and its treatment. And of course, you are using also more medication when you're aging, which some of them do cause erectile dysfunction. But vascular causes are common, and we can prevent this. And basically, you have the hardening of the vessels and the narrowing of the vessels, which is caused by cholesterol, which is caused by smoking, which is caused by a sedentary lifestyle, and then also caused by really diet. So this can be avoided. We have what is called the deadly quartet of obesity, diabetes, hypertension, and dyslipidemia. All these do affect erection. Things like prostate cancer, in fact, erection, AD can be a pointer to early prostate cancer. And so therefore, when we have a patient with erectile dysfunction above 40 years, we'll always do his PSA levels to see that they are between 0 and 4. We also do the cholesterol levels, we do the testosterone levels and sugar levels, just to see what is happening. Another important factor about erectile dysfunction being, especially the one due to vascular causes, narrow blood vessels, which will be cholesterol and hardened blood vessel. The artery to the penis is about 0.2, is about 2 millimeters in diameter. and the second narrowest is the one to the heart vessels, which is about 4 millimeters in diameter. And that means when you have erectile dysfunction, you can almost predict if things are not changed, then you're going to have a cardiac event in the near future. And therefore the two go together. And we have a lot of interest in erectile dysfunction, because then we can avert my heart attack in the future. Continue, next slide. So those are the risk factors. I think we've mentioned about them. Exercise is important. Of course, when you do exercise, you then work on the obesity, you work on cholesterol, you work on diabetes and hypertension. Certain prescriptions are the dowels we use for ulcers, the dowels we use for hypertension, some for treatment of cholesterol, and some of the medicines we use for prostate enlargement or prostate cancer treatment all cause erectile dysfunction. Other factors will be surgical, like if you have done a radical prostatectomy for prostate cancer, yeah, we have about 30% of our patients ending up with erectile dysfunction. The one for benign prostate enlargement, however, the TURP does not cause erectile dysfunction. Depression and anger, socioeconomic status, and quality of life, all these are things that would add up to causing erectile dysfunction. Good. So we continue. Again, we revisit this diagram. Remember, the brain will be above the hypothalamus level. And what you're having now, the P-shaped gland is the pituitary, which produces luteinizing hormone and follicle stimulating hormone. And normally the luteinizing hormone would stimulate the testes to produce testosterone. And when there's too much testosterone, there's a negative feedback back to the pituitary to order the testes not to produce more testosterone. Next slide. And the FSH instructs the penis to produce more sperms. And let's talk about andropause or male menopause. Some people say it's midlife crisis, but you can have an androgen deficient aging male or a partial androgen deficient aging male. We know that testosterone declines by 1% every year after 40 years. And therefore, when it declines and it is below the normal level, then you start getting some symptoms. Remember, next slide. This is just showing the level of testosterone as you move on. You find that, next slide, just previous slide, please. So you find that the testosterone declines. You are at peak in your 20s. And by the time you are 75 and so, the testicles have become small and the testosterone level is basically small. And by the age of 85, you're having a low testosterone count or level. And remember that, next slide. Remember the slide we talked about. You have that young man getting a lot of hair, getting a lot of muscle strength and muscle bulk, having a reduced fat, having a high sex drive, good memory, very high hemoglobin, good physical endurance. This now reverses when you have low testosterone. You have the hair becomes sparse, the body mass reduces, and you have more increased abdominal fat. You have reduced sex drive. You will start getting hot flashes like the women. You start getting poor memory. You start getting mood changes, and you think people are not respecting you the way they used to. And you get frustrated because of the physical endurance as well and reduced work performance. Next slide. So these are the things that happen. You have a reduction in the testicular tissue mass. I guess the testis has already done its work by that time. There's a testosterone decline, and then you have a general systemic decline, starting with the blood hemoglobin level goes down. Your cognitive function goes down. Emotional changes are obvious. Then you brought in other issues like we had in the morning of having to use a laptop and internet challenges. So IT complications, you can imagine this at the age of 85 or 70. And having to remember a PIN, your password all the time. This also brings a lot of issues. In the cardiovascular system, you get fatigue. Most patients will tell you they cannot go uphill. They used to climb that hill 5, 10 times a day. They cannot do even once. They get short of breath and they fatigue easily. The muscle mass reduces and the bone density also goes down. Then you have urinary issues, so basically erectile dysfunction, low libido, and of course the prostate is disturbing you at that time. Other organs that fail is like the gastrointestinal system. You find that you're getting more constipated. You can't take a lot of food. You feel full after little food feeds. And this is just a slowdown, just like the knees are slowing down, even the gastrointestinal system slows down. And next slide, please. But what can we do about improving the quality of life as you age? There's advice on regular, moderate physical activities. You cannot do vigorous activities. So these are activities like walking. If you can jog, that's good. If you can tone your muscles, that will increase the bulk and improve your bone density. You need to get regular sunshine. You need dietary advice in terms of a lot of vegetables, fruits, and high fiber diet just to help you with the bowels. Lean source of protein because you want to avoid getting that abdominal fat. And you have to watch your portions because you're not engaged in a lot of physical activities. You don't need a lot of energy. And the lifestyle modification will be manage stress, just accept that things are the way they are at that point in time. Avoid substance abuse, coffee, caffeine sometimes irritates the bladder. Stay mentally active. We know like substances like alcohol, they are good. Sometimes they provoke the desire for sexual intercourse, but we know when you're taking them in a prolonged time, for a prolonged time, they affect the liver, and that does affect the testosterone level as well. It lowers the testosterone level. You need to stay mentally active by playing games and involving yourself in reading and activities that challenge your brain. And then you answer call promptly. This is not a phone call, but rather a call of nature. If urine, don't postpone because you don't know where the next toilet is, and you don't know how the bladder will act. Bowel, the same thing. You have to just answer these calls promptly. You've got to socialize and be amongst people because you need support. Regular medical checkups. We advise men to have annual PSA levels after 40 years and continue annually until advised by the doctor. Otherwise, we advise men to have cholesterol checkup. We advise men to have sugar checkup. We advise men to have their blood pressure checked regularly. And of course, we advise that you watch your weight, watch your body mass index, and involve yourself in regular physical activities. It's also advisable to have a colonoscopy, OGD, checking the intestinal systems at least once every 3 years. It's good to have a cardiac checkup for at least once in a year, as advised by your doctor. And it's also good to have some nutritional advice where possible and consultations. Dental checkups are very important as you age. You all well know that the teeth start falling and they threaten. Just touch me and I'll fall off. So you need regular dental checkups. We have a lot of discussion about and interest in terms of supplements, vitamin C, vitamin D, and testosterone. Of course, one of the things that you want to maintain is good cognitive function as you move on, memory, good memory. People have thought that if you are using a lot of vitamin C supplementation, vitamin D supplementation, that may help you perhaps in terms of memory issues. On the other hand, testosterone, if replaced, would help reverse all those things, give you a good body mass, less fat, more cognitive function, good sexual drive. And so there is a lot of interest in the international arena about testosterone replacement therapy. Just like the women do estrogen replacement therapy. It is feasible. The only caveat here is that testosterone is what drives prostate cancer. So if you have an indolent cell, not very active, and you expose it to testosterone, it may flare up and become cancer. And so when you have testosterone replacement therapy, you have to have a doctor checking your PSA levels regularly. But it is a viable option and people are doing it. And the idea is just to keep you moving on. Next slide. No, I think you skipped one. The picture, that one. So we started from the time we crawled and we talked about the diseases that happen, the cryptorchidism, the hypospadias. We came to the boy there when you get mumps, which affects the testicles later in life. We came to the boy playing there who could get testicular trauma and in a few years could get testicular torsion. We came to the man, the young man, who then at that age you get infections like prostatitis, you get sexually transmitted infections, and you also could get torsion. You could also get testicular cancer at that age. And then we moved on to the man who is upright there, sometimes could get erectile dysfunction, could get testicular tumors, and could get early lower urinary tract symptoms. And then you have the man there with that protruding tummy who has low testosterone and has perhaps BPH, has maybe prostate cancer, maybe cardiac issues, maybe diabetes, hypertension, dyslipidemia. And then you have the man who is bending, reduced body mass, reduced bone density. At that time, invariably, all of them have had issues with the prostate. And so when we are looking at this, we are looking at the evolution of the male species, the male man and the man. And we go through all these stages. And if we could get the upright man, the tallest man there, if we can maintain that into our old age, that would be the ideal. I wish the body could stop aging from there, but that's not the reality. But you can do that. You can try and maintain that at least by physical exercise, good diet, avoiding the metabolic syndrome, avoiding use of substance abuse, avoiding medications that affect your system, and having regular checkups. And so when you definitely age at some point, but at least you can maintain your body mass, you can maintain you can reduce the abdominal fat, and perhaps keep the cognitive function well. Yes, so that's the idea. That's the age there that one may think about testosterone replacement therapy, vitamin C, vitamin D, but all this we find in diet. In terms of prostate enlargement, we still talked about diet. In terms of aging, there's nothing you can do about diet, but we talked about the lean diet and a lot of fruits and vegetables in keeping with the other comorbidities that you may be having at that time. I think next slide. And we've talked about many diseases, and I would like to end by saying that man is born broken. He lives by mending, and the grace of God is a glue. This is a quote from Anthony O'Connell in 2009. And with your permission, I would like to stop there. Sorry for the initial inconvenience, but I hope we have time to answer some questions. Thank you.
Wow, that was a mouthful, Doc. I think, yes, we can have a few questions as we try to wind up because of time. And maybe I'll take some of the questions that have been dropped at my desk with anonymous attendee who is asking, why do I have testicular pain after an erection?
Yeah, testicular pain after an erection could be, there could be something in the testis. Could it be a cyst? Could it be a varicocele? Could it be an infection in the, or inflammation in the testis? That's a possibility. And then you could also be having prostatitis, which there's a connection between the testis and the prostate, through the sperm duct, which enters into the, if you remember that picture of the radical prostatectomy specimen, the sperm duct enters into the prostate. So if you have one inflammation within the prostate, sometimes you get pain in the testes. It could be that, or it could be nothing. But you need to perhaps see a urologist who will then assist you. Yes.
Yes, another anonymous attendee is asking, is semen retention safe? Does it reduce the reduction of testosterone in aging?
What is that? Semen?
Semen retention.
Yeah, that means you retain semen because you're not having sex, regular sex. It does not affect the testosterone. I think the reverse is true. Low testosterone, and less sexual activity, and then perhaps if the testicles are still working well, you get reduced semen or increased semen and some retention. But that doesn't really affect, the body is able to regulate itself. Otherwise, we remember we start producing spermatozoa or semen after puberty, and then we are supposed to wait until we get married to engage in sexual intercourse. So you find that it doesn't affect the testosterone at all. In fact, the testosterone will be going up in that age group. Yeah, thank you.
Thank you, Doc. Still on the Q&A section, is it true that prostate cancer is caused by a lot of ejaculation?
Not true. In fact, it has nothing to do with the sexual intercourse or lack of it, or how many partners you have. We see it in those who have chosen to be celibate, and we also see it in those who are polygamous. So it has nothing to do with sexual intercourse or the number of sexual partners. Yeah.
Another one is asking, what could be the cause of small lump in the testis and painful when touched? Can penis be enlarged? I think those are two questions.
That is in the testis or penis?
Number one is, what could be the cause of a small lump in the testis and painful when touched? And then the next question is, can penis be enlarged?
Number one is the causes of small lumps in the penis. The commonest is an epididymal cyst or a spermatocele. Usually they are not painful unless they are too big. Another one is a varicocele. And then the third one will be inflammation. If you have epididymitis, you can then, that is usually painful when touched. This is inflammation of the epididymis. And when it is painless and there's a lump in the testis, we worry more about cancer when it is painless. So sometimes it's better to have a painful lump. Yeah. And then the penis enlargement, that's a question people ask, but and you find we see people coming and they have more than above average penile size and they still want it enlarged. I wonder, maybe it is better to manage the expectations at the brain level because we are not able to enlarge the penis, and nobody should cheat you that they are able to do that. But however, when you're using the PDE5 inhibitors, then you have this continuous blood flow to the penis, and therefore it will be slightly bigger than usual. We do this when we do radical prostatectomies. Because of touching the nerve to the penis, sometimes we give the PDE5 inhibitors, and that are used for erectile dysfunction, and that seems to improve the size of the penis, just making sure it doesn't reduce, because we touch the nerve and it's not being used for a while. So we just try to give that to maintain penile size, not to enlarge. Thank you.
Thank you for that clarity.
Yeah.
There's another one who's asking, 2 weeks ago, he had intense sexual intercourse, and right now he cannot be able to erect. Is there a health risk that he should be aware of so that he can seek medical attention? And maybe you can combine with what are the effects of masturbation?
Okay. I think the one having sexual intercourse depends on the circumstances. Maybe he feels guilty about it. I think the issue about erection, the fact that you had sexual intercourse 2 weeks before, means you had an erection. And therefore, if you are having any issue, then it is more of psychological. And therefore, it's just a question of him debating with himself. Was it appropriate? Or why is he lacking an erection after that? And he had one. I think it's more psychological rather than organic problem. The effect of masturbation is one disease that we did not talk about, premature ejaculation or ejaculatory disorders. And when you get into the habit of masturbation, then when you finally get married, you end up with a problem of premature ejaculation, which then requires a treatment. Means you ejaculate within less than a minute, and therefore once you ejaculate, then the erection would die off and maybe take longer to get another erection. So those are the long-term effects of masturbation. And then depending on how they do it, we've seen patients who come in with penile scarring, what is called Peyronie's disease. You get a plaque on the erectile tissue, and you get a penile bend. Yeah. Good.
I think this is a discussion that cannot end within a day. There are 2 questions that which is the likelihood of reversal of erectile dysfunction, and does a surgical interventions play any role for ultimate recovery? Maybe you may combine with I've experienced ED with my girlfriend, but I'm okay with others. Is it normal?
Well, erectile, that person is defining what is called situational erectile dysfunction. You're okay with one partner, not with the other. So that's called situational erectile dysfunction. It means you have no erectile dysfunction. It's just a situation. Depends on who. But in terms of erectile dysfunction, the treatment is number one. We talked about exercise, diet, reducing the cholesterol level, checking on the medications you're taking. And then we do give medications called PDE5 inhibitors, the likes of sildenafil, the likes of tadalafil and vardenafil, which all work very well if taken in the right dosage and the instructions from the doctor. They do give you erection. We also check the testosterone level. It is low, we raise it up. Sometimes they do not work and they fail, and you go to the second line, which is intravenoso alprostadil injection, what is called Coverjet. You inject into the erectile tissue and you get an immediate erection. Other things that have been tried are like the vacuum. You use a vacuum to pull blood into the penis, and hopefully it is locked there, and then you get an erection. Surgical measures in terms of correcting erectile dysfunction is in the severe state where everything has failed and the patient is well counseled. Therefore, You can pull, insert penile implants, be it rigid ones, where it means you move around with an erect penis, or inflatable ones, where you put in inflatable device where in the corpora cavernosum, it's erectile tissue. And when you want an erection, you just pump, and then you get an erection, and after you're done, you release the air. So that's possible, but that is in extreme cases. Yeah.
When one is infected with a urinary tract infection, does it cause erectile dysfunction 50-50%?
I think we've got to separate the two. There is a urinary tract infection, which is a urinary tract that is affected, as opposed to genital tract infection, which is then the urethra having some issues, and the penis and the testes. So when you have a sexually transmitted disease, or if perhaps if you have a penile ulcer, for instance, then it will affect your erection because it's painful. And the fact that if you have a painful leg, you cannot walk is the same thing. If you have a painful penis, then you cannot use it. So yes, things like penile ulcers, balanitis, penile plaques, all this will affect erection just because of the pain.
The other question is, what is the cause of blood in urine, especially after sex?
Okay, very good question. You can have blood in urine. That may happen, but more importantly is what we call hematospermia, blood in semen. And usually this is caused by, it's commoner in young men. And when you have it in young men, it's mainly because of veins, again, around the opening of the bladder, what is called the bladder neck, and the prostate. You have some veins. So that during ejaculation and sexual intercourse, some of these veins burst and you get blood mixed with semen during ejaculation. That's called hematospermia. So those veins of varices, we treat them endoscopically, where we go in and burn them, just like when people bleed from the nose, they get cautery on the nose. So we do that, and that seems to help. The other cause of blood in semen is from the prostate itself, and this could basically sometimes be a pointer towards prostate cancer. Or if we've had patients who had prostate biopsies when we're investigating for cancer, then when they resume sexual intercourse, the needle may pass through the ejaculatory system, and you end up with blood in semen for about 2 to 8 weeks, and that's usually self-limiting. You also have other issues that we must remember, what is called the hematological issues. If you have issues with the platelet, if you have issues with anticoagulants, if you have issues with some blood cancers, you can still get blood in semen. Blood in urine would be, there's a breach in the lining of the urinary tract, that is from the kidney to the ureter to the bladder through the prostate. So you could have a stone within the kidney or the ureter. You could have a tumor in the kidney or in the ureter or in the bladder. You could also have a bladder stone causing all this. You could have infection causing hematuria as well. So there are many causes, and basically it's good to then see a doctor. Prostate enlargement also, if it is too big, the veins over the prostate rupture, and you get bleeding from that as well. You can also have urethral bleeding because of warts or any urethral wound. Yes.
Great. I think, Doc, we are getting more questions. Yes, we are encouraging you, our audience, to share more questions on the email that we've dropped on the chat box and also our WhatsApp line. So maybe we'll have 3 more questions so that then we can call it a session. How does varicocele occurs, and is it treatable? Maybe you may combine it, Daktari, with the effect of vasectomy, and does it affect the sexual drive?
Varicocele we mentioned, we remember we talked about the kidney, the kidney being just above the testes and the testes going down to the urethra. And that means you pull along the vein and the artery down to the scrotum. And therefore, when the artery pumps blood into an organ, but the vein draws blood. So during breathing in and out, we pull in blood. When you breathe out, the blood may go back. So to avoid that going back, you have some valves within the veins. And so when these valves fail, you allow blood is allowed to flow back during breathing out and stagnates. And when it stagnates, be it on the legs or the testes, you get the veins becoming tortuous, the veins becoming dilated, and that is what we call a varicocele. Varices means just tortuous in medicine, and that is treatable surgically. For the legs, you can even use laser these days. Even for the testes, we are advancing in terms of laser and embolization, but basically we treat them by laparoscopy, like get the veins in the tummy, in the abdomen, or in the groin, or in the scrotum. Vasectomy means you're actually cutting the sperm duct that connects between the testes to the prostate and to the urethra. So you disconnect that, and the basic achievement is that you block spermatozoa from getting into seminal fluid. So you still have seminal fluid from the seminal vesicles and the prostate, and therefore you will have one ejaculation, but that ejaculation doesn't have spermatozoa. You are working outside the nerve system of the penis. You're working on the scrotum, and therefore vasectomy does not affect erectile dysfunction or erectile function, and does not affect you in terms of prostate cancer and the rest. It's a safe procedure, and it's one that would be encouraged, that men should take it up. Do I read the questions on my hello?
Doc, maybe I can just share two questions because of time.
Yes.
And you, on your presentation, you mentioned about the animal proteins linked with the BPH. Kindly clarify on the same.
Yeah, in terms of diet, I think an animal rich in animal fat is good for any organ, and I think and it's so also for the prostate. And therefore, when you're taking diet high in calories, then you may end up having also an enlarged prostate. We know that if you're taking meat, specifically well-done red meat, that has been shown to be related or associated with prostate cancer. On the other hand, soya sauce, the Japanese have demonstrated that soya sauce would be one way of preventing prostate cancer. And so vegetable-oriented plants, or beans or seeds, because I think what they do have is what is called phytoestrogen, that is plant estrogen. And you know, testosterone is opposed by estrogen. So the phytoestrogen may reduce or oppose the testosterone, and you get a reduction in the size of the prostate, or a reduction in the chances of getting prostate cancer. So it is true that diet, we need to watch on the diet. There are things that are mentioned, perhaps not fully proven, but things like using pumpkin seeds, very important in terms of discouraging prostate enlargement. Use of tomatoes, broccoli, watermelon. Some people talk about cassava, and of course the muiri tree, the prunus africanus. I think that also is very important in terms of prostate health. I don't know the dosage, how many glasses you should take, but it is important. Yeah.
How can I be able to increase my testosterone levels without using medications? And also maybe you can link this question, Daktari, with some people talk about men boosters. Does this increase libido? And if yes, does it have some side effects?
Yeah, libido is a factor or function of testosterone levels. The more the testosterone, the better the libido. One way of increasing testosterone is exercise. You can increase your own testosterone production by exercise. Number two is by reducing alcohol intake. We know that alcohol eventually, if taken chronically, will reduce the testosterone level. Those two are important. And then, of course, you avoid medication that would counteract your testosterone. Yeah, like the ADT, some of the dawas we use for prostate cancer. Yeah. And then what was the next one? That was testosterone, and the next one?
The next one was number one was to increase testosterone levels.
Uh-huh.
The other one is some
The
people
boosters.
talk about men boosters. Yes, men boosters.
Yeah, I think the best booster is exercise. Is a lifestyle free of smoking. Is a lifestyle of moderate alcohol intake, and it's a lifestyle where you watch your diet. The male boosters, there are all these herbs and supplements that people talk about. They're all in the diet. If you take the right diet, you get them. Therefore, I don't think it is worthwhile to spend a lot of money buying those things in the internet. You just need to have a strict lifestyle measures, exercise, and doing things in moderation is better than being on the internet looking for the next potent booster. Yeah.
Maybe Daktari, you can check any questions that you have on your end.
Yes, one is for an individual at 60 years, what is the recommended therapy to the same? I don't know what is the same. I don't know. I don't know, but perhaps if it is erectile dysfunction, you need to go to the doctor, have a checkup, have your cholesterol checked, have your PSA checked, have your sugar checked, have your testosterone checked, and then the doctor will base his treatment on that. If it is a BPH, then you need perhaps to start with the alpha blockers and 5-alpha reductase inhibitors, and then have the doctor follow you up. If it is a raised PSA, then you need to have an MRI perhaps, and then your prostate examined, and perhaps a biopsy to see whether you have BPH or prostate cancer. The next one is, does a prolonged refractory period after ejaculation be a sign of ED? This the refractory period is the time after ejaculation, the time you take to get another erection. And there are people who have a refractory period that will be an hour, others an hour, 2 hours, 3 hours, others 24 hours, others 3 days. It all depends on your stage in life and your age and your comorbid factors. Yeah. I think a refractory period longer than 1 hour would not say that you have ED. Maybe one has to check on many other things, your physical activity during the day, the situation you're in, your other comorbid factors, but it's not a sign of ED. Once you're able to erect and have a go, even if it is once in 3 days, you don't have ED. Yeah. Does appendectomy affect men's health? It doesn't. It doesn't, because the appendix is quite far from the reproductive system. It doesn't. Yeah. So those are the questions on my screen.
Thank you, Daktari. Maybe the other thing, as we summarize, where can we be able to locate you and look for these services?
Okay. One is that I'm based at Professor Nelson Awori building, 4th floor, room A4. We consult on Tuesday, Wednesday, and Fridays. We now have a good cohort of urologists, and previously we were few, but now we are many. And you can almost get a urologist in any county, and therefore, and they are all very well competent, and therefore get into that habit of seeing a urologist. It doesn't have to be Dr. Waweru, but just see a urologist for checkup, because we want more men to come out. I'll give you an example. In the year 2000, I started what is called men's clinic, Wellman Clinic at the Mater Hospital, and others followed the Aga Khan and the other hospitals. And what I see, since I still consult at the Mater Hospital, the clinic still runs, but what we see is that most of the patients that we do have with early prostate cancer emanate from that clinic. The patients that we see with early colon cancer come from that clinic. The patients we see with that needs help come from that clinic, because once you have a high cholesterol, that is taken care of. It takes care of many things. And therefore, that's just a factor to show that, yes, you need to be checked. On the other hand, if you look at the Well Woman Clinic, most of the breast cancers, early breast cancers, will come from that clinic. Early cervical cancers and early colorectal cancers. So it's important to have regular checkups, and we should get into that habit. It's cheaper to be checked than to be treated. And the quality of life is preserved when a disease is caught early than when it is caught late. And therefore, I would just encourage you people to seek help from urologists and to seek help from other relevant specialties, be it a cardiologist, diabetic expert, kidney expert, because it's important. Yeah, thank you. Thank you very much for listening, and sorry for the hitch we had in the beginning. I've tried my very best in the circumstances, and thank you for your patience and for tuning in. Thank you very much, and have a good day, and God bless.
Thank you, Daktari. Thank you so much. We are humbled and honored to have you. Thank you for our men who joined us today, and same to our women. APA Insurance is committed to your wellness. We have a wellness department. So if you're experiencing any challenge in regards to the same, please reach us on our wellness lines, and we should be able to help you. Otherwise, on behalf of the APA management team, the APA medical department, the wellness team, we want to thank you so much for being part of us. Daktari will be sharing with you the other questions. We have close to 100 or more, so that we can see how we can respond to our audience. Otherwise, thank you very much, and kindly have a blessed week ahead, and God bless you. We can all leave at our own pleasure.
Thank you. Thank you. Good day all.